Good afternoon, everyone, and welcome. I am very pleased to have Dr. Kelechi Ohiri joining us today for our Global and Community Health Seminar Series. So on behalf of Harvard School of Dental Medicine, Dr. Ohiri, I would very much like to welcome you as our honored speaker for today. Dr. Ohiri is the Chief Executive Officer of the Health Strategy and Development Foundation, a healthcare advisory firm. He is also currently a visiting scientist at Harvard University, the founder of the Healthcare Leadership Academy, and partner at Flint Atlantic, an Africa-focused social impact investment firm. He previously served as special advisor to the Minister of Finance, as well as two ministers of health in Nigeria. Prior to this, he was an engagement manager with the London office of McKinsey & Company, where he served clients in Europe, the Middle East, and Africa. He has also worked with the World Bank in Washington, D.C., and focused on social protection and strengthening health systems in Asia, the Middle East, and Africa. He has written numerous policy papers, peer-reviewed publications, and co-authored books on health systems. He has served on expert advisory committees for the Institute of Medicine, U.S. Centers for Disease Control and Prevention, the World Bank, the Global Fund, and the World Health Organization. He's also served on the board of the WHO's Alliance for Health Policy and Systems Research, and has been an advisor to AMREF's Innovate for Life initiative supporting healthcare innovators across Africa, and currently a member of the Program and Policy Committee of the Gavi Board. So Dr. Ohiri, you have an incredible life experience, and we're so excited that you are here today to share your experience with our students and faculty, and also to share with us some of your thinking on health policy and how we as burgeoning healthcare clinicians, researchers, and potential policymakers can contribute to the evolving conversations around healthcare policies globally and how we can help make a difference locally. And so maybe you could just start by telling us a little bit about yourself and your career, and if this career that is so amazing has followed the trajectory that you projected for yourself when you started out in medical school. Big question.
Very big question. Thank you very much, Jane. I'm really honored and humbled to have this opportunity to speak to you and some of the students who are on this call. And as you read out the my bio, it was also humbling, and it might seem as if I actually had everything figured out and it was well orchestrated and planned, but
it does.
But it's never. I mean, you know, the benefit of hindsight is all looks very well thought through. But I would say that if there has been a consistent theme in my approach to both my career and to public health in general, it's been that of asking the right questions. I started off the journey looking for answers. I mean, like most of the students, we all got into healthcare because we probably felt the calling or felt the need to impact humanity in one way or another. And for me, it was as simple as I want to help people, and medicine seemed like the right approach to doing that. But then if you've ever worked in a low income setting, either in a low income country or in a middle income country, or even in a rich country like the United States, but working with underserved populations, you'll begin to see that, you know, the system has a lot to do with health outcomes. And that's both the health system as well as other social determinants of both poor health outcomes and inequality. And for me, that's begun to shape my interest in addressing population health first, and then also addressing systemic issues. And so that's what led me to asking those questions. Why are the poor worse off? Why is the woman whose child, you know, has maybe severe neonatal sepsis coming back with the next child with the same issue? What's the issue in her environment or system that's, you know, doesn't prepare her for the sort of positive health outcomes that we look for. And that line of questioning led me to public health. I must say I didn't start out thinking, oh my God, I want to be an epidemiologist or anything like that. I just wanted to be a doctor and see patients. But then when confronted with the enormity of the challenge in a low-income setting, then you'd want to address the problems of populations, because you suddenly realize that being an excellent physician and waiting for people to fall sick and come to you is not just enough. And then so that led me to coming to Harvard for the graduate programs in public health and in health policy and management. Mm-hmm. And of course, while here, I got exposed to a lot of people, and a lot of information, and this new vista of opportunities opened up, and was inspired by a lot of people, including Paul Farmer, Jennifer Leaning, and some of my other professors. And when I finished, I joined the World Bank through something called the Young Professionals Program. And the question I was asking then was, if it were possible to actually have impact in the world, if you work with an organization with the resources, the reach, the access to government, the convening power that the World Bank had. And perhaps what I'll bring to the table is a heart for the poor and wanting to do the right thing, that combination actually result in better outcomes. And it could, but of course, the answer is not always as straightforward. And then a few years into my time in the World Bank, the realization that in Africa, the health systems were mixed. The private sector played a significant role in how even the poor accessed care, got me interested in the private sector. Something that, historically I was not particularly looking at, because the model I was familiar with in the World Bank was working with governments as agents to do better for their citizens. And so in places like Nigeria, the private sector accounts for more than 60% of healthcare being provided. And this is the for-profit private sector as well as the not-for-profit ones. And so some of those questions, again, in addition to an encounter I had in Egypt with representatives of a particular consulting firm, led me to apply to and join McKinsey and Company in the London office. And I did a lot of work in healthcare with the NHS, but also began to look into Africa. And then, like I tell everyone, I was minding my business one Friday during happy hour, and then I got a call. A senior colleague and mentor, Dr. Mohammed Pate, had just been appointed the minister in Nigeria. And then he called me and asked if I was ready to come back to the continent to help. I, of course, initially told him absolutely not ready to do something. And so eventually, he was quite persuasive, and I ultimately took the leap of faith and went to Nigeria and served as a senior advisor. So 4 years later, 3 ministers later, I had seen everything about the public, a lot of things about the public sector, the private sector. And so that I will think rounded out a lot of experience I'd had, in trying to tackle issues. And then after that, left government and began to work on HSDF, supporting governments in Nigeria and in other countries in sub-Saharan Africa, and also worked on some of the other things that you had mentioned. So I'll say in summary, it's really been a journey of asking questions and trying to say what levers would work in improving health outcomes for people, particularly the poor and vulnerable. And that's what has characterized my career path. And everybody's career trajectory will be different depending on multiple circumstances and reasons. But that's sort of like mine, and I'm still on that journey, and I'm wondering and looking forward to what next it would, fate would have in store for me.
Well, it sounds like it has been a fascinating journey. And I'd love to hear your thoughts on contrasting the way the public sector and the private sector work when it comes to trying to affect change. Do they seem to have the same priorities? What are the tools that they use? Do voices matter? I heard a presentation that you gave as part of the Harvard Ministerial Leadership Program, and you were talking a lot about data. And I'm curious if the public and the private sectors use data in the same way, for example.
Oh, great. So I would say, there are instances where, I mean, you can't do without the public sector. I think we need to start with that, right? And the public sector plays many roles, whether it's the power of the state in regulating an entire sector, in setting enabling laws, and governed by whatever philosophies the state is governed by, and these are not usually determined by the health sector. And in an ideal situation, the state is acting on behalf of its citizens, right? And it ensures that even the poorest citizens have access, in this case, to basic healthcare. And there are responsibilities the state has in service delivery to ensure that everybody has access to services, right? Part of that, is also working with the private sector. And the engagement with the private sector could be through creating the enabling environment, right, for the private sector to thrive. It could be using incentives and disincentives to ensure that the private sector is also meeting a social outcome or objective. And sometimes it might just be the state needs to step back and allow the private sector do its work, right? And in that sense, the state sees its role much broader and puts the citizen at the center of whatever system is being designed. The poor person, the poor woman in rural, Malawi or northern Ghana, wherever, just wants to have a safe childbirth and is not exercised by any philosophical arguments as to whether the doctor is representing a private provider or a public provider. As long as she's alive, her child is healthy, and out-of-pocket expenditure is not that significant to impoverish her, right? And so if we always keep the person at the center of any system we design, then in that case, it tends to work very well. I've noticed that the private sector fundamentally, it's not homogeneous, right? There's the private sector in many places that's like nonprofits, mission-based, sometimes it's run by religious organizations that have a social mandate, right? And they actually, in many instances, reach the poor better than the government does. There are also for-profit private entities that want to generate a profit for its shareholders, and this cuts across the entire value chain from manufacturing all the way to service delivery, and they have their roles to play. So they don't always come at it from the same angle. And that, to answer your question, where you have things that are merit goods and private goods, right, the private sector works. But there are inherent market failures in healthcare that require the government interventions, right? Immunization, pandemics, etc. So it requires a government intervention. However, that intervention would be the government convening all sectors together to align on a common purpose. So for instance, in the United States, right, the government invested heavily in the research and development that's culminated in the private sector being able to develop a new technology of mRNA vaccines. And the big pharmaceutical companies were able to take that from research and develop the vaccines the world used in an unprecedented, time, right? So that was the public sector and the private sector coming together to provide that. So I think it's a false dichotomy sometimes when we look at public versus private. The question is, how do we, or the public sector being the arm of government, create an environment where there are synergies, and at the end of the day, the individual, everyone, the citizens, particularly the poor, benefits from, policies and delivery of health services. I think that's sort of my bias in terms of my philosophy about this. And then with regards to data, people say data is the new oil, data is the new gold, etc. I think it's the private sector may be interested in different types of data that pertain not just to its services, but also to its clients and to its business. The government looks at different data sources, but more importantly, I mean, in many low-income settings, the quality and availability of data is a problem, but the use of data is important. We've been involved in evidence-informed decision-making. And I think after COVID, most of us have realized that even in the face of very good, credible data, decisions are still made largely, sometimes bringing political biases, macroeconomic considerations, and there are other considerations that are brought to bear in decision-making. But we still need data to guide us. And in the best case scenarios, the data guides more directly policies. But my view is, in whatever system you design, if public welfare is at the center, then you make better use of the data, and that will guide the type of decisions that we'll make.
Great. So, I was setting you up to ask you another question. Coming from a dental school, I have to work dentistry and oral health into our conversation. One of our colleagues at Columbia, Mary Northrup, has written that access to oral health care is a key indicator of disparities. And Benoit Varenne from the WHO, who's the oral health director, recently had a posting in the Journal of the American Dental Association talking about how for years we have been working on building the evidence base of the need. Over 3 billion people, 3.5 billion people suffer from oral disease. Many people around the globe have lost teeth, have periodontal disease. And these issues are now finding their way onto the minds of leadership in many countries. At the WHO, there have been resolutions. Sri Lanka, I think at the end of 2019, resolved to incorporate dental care into its universal health coverage plan. Many countries still do not include dental care in their universal health coverage, and WHO is now beginning to take steps to promote inclusion of dental care in universal health coverage because of the recognition that so many people desperately need access to dental care, and because of a greater understanding of the oral systemic relationship and how access to preventive dental care can help mitigate the impact and progression of many non-communicable diseases. And so we're seeing a call for dental care to be incorporated into non-communicable disease strategies. And so I'm wondering if you could comment on your experience seeing whether dental care has been incorporated into universal health coverage, and if not, what your thoughts are and how we can in our community do a better job raising awareness, and what kinds of information, what kinds of data you think would be helpful to people in ministries of health and finance, and maybe groups like the World Bank and the WHO who can help us advance the cause.
Thank you for that setup. So actually, one of my close colleagues, who was a co-author of a book we wrote together when we were at the World Bank, Marco Vujicic, is the chief economist of the American Dental Association, and you guys have an amazing,
well known to us, yes.
in Marco's office was beside my office in the World Bank, and we debated several issues over the years. And so you have a phenomenal person and just a good human being in there. So the issue of oral health and universal healthcare coverage, I think it's important to go to take like a historical perspective of how do things get on agendas of global health. Unfortunately, we have a lot of verticalization of, global health, where things become priorities based on specific interest groups. So it could be malaria, or it could be HIV and AIDS, or COVID in this particular instance. So there's a lot of verticalization and a disease focus of things. And I think this is how the practice of public health had evolved over time, was how do we prevent this particular disease or that particular issue from coming, as opposed to what we're now seeing with the move towards universal healthcare coverage and WHO's more recent definition of health, right? Which is looking at total well-being and looking at, you can't say, somebody has good health without including oral health, right? And so it shouldn't even be a debate as to whether or not oral health should be part of what makes up universal healthcare coverage. But the history of verticalization, for whatever reasons, and it's not just particular to oral health, there are other things called neglected diseases. Why should they be neglected? If I suffer from them, then it's really important to me. So we should look at the whole human being in terms of health and well-being. And hopefully that's what universal healthcare coverage should be. It should be really looking at the whole individual. And secondly, I think it's particularly important because of the way it's not included in a lot of financing. A lot of oral health is financed out of pocket. And anything that is financed out of pocket means that gross inequities in access ensue. So those who are disproportionately affected by poor oral health are the poor, who have to pay out of pocket. So when one looks at the proportion of income spent on any specific thing, then you find out that the poor who, and in a lot of parts of the world are earning their living in a subsistence manner, cannot afford that, and therefore that keeps on subjecting them to poor oral health outcomes, etc. So there's a major equity issue, which universal healthcare movement purports to, be interested in addressing. So definitely it makes sense to do that. So that leads me to what then should be the perspective in terms of addressing these things. Well, I think there is the issue and the challenge of the focus on prevention versus the focus on curation and rehabilitation, right? I guess like in many things, most of oral health is preventative, right? In a large sense. So, and sometimes when things are too simple, people don't take it. So tell people, take care of your mouth, whether it's like brushing your teeth, flossing, or whatever. It sounds like, well, why are we even discussing that? The same thing, hand washing was one of the major, interventions to prevent, infections, and even during COVID, like, oh, wash your hand for 20 minutes. But as simple as those preventive measures are, compliance is very low. Importance placed on them is really, really low. And that's, and that narrative tends to play out in terms of what people ascribe priorities to. But if, it was a case of like high-end curative care or emergency situations, then it will rise to a level of importance. So in emergencies, so I mean, there's this whole, and I don't know if I'm offending dentists, but you hardly see a dentist in an ER because it is perceived that, dental conditions may or may not, present as emergency. If they're emergency, somebody else can take care of them. But we have a psychology in healthcare where things that present as emergencies rise up the priority list, right? So when COVID started, for instance, and it was something distant and didn't affect anyone until it became an emergency, a pandemic of disproportionate levels, then we pulled out all the stops to address it. So I'm not making a case for oral health related issues to now show up as emergencies, but these are some of the constraints that we face in actually integrating that. So what can we do? One, I think we can increase our advocacy, right? And continue and sustain this level of advocacy, because it is part of well-being and human health.
Mm-hmm.
Second thing is that we should push for a more integrated approach to health and well-being, and automatically this, and I think the world, we need to converge around that. That's, again, you can't have health and well-being without oral health, without health in every organ, every part of the human body, for instance. And so it's not, a separate thing or a side specialty to be considered. It is part and parcel of the human body, and part and parcel of medicine, and part and parcel of like whatever we should address in terms of complete health and well-being. And so, so framing it in an integrated manner would be helpful. And I think the third element is really the economic argument, and looking at the financial impact, particularly on the poor, and access to oral health services, and ensuring that either in health insurance packages, coverage, whatever, that it is actually part of that. It's not, considered as something additional or supplemental. It is essential. So it should be part of, essential, the essential health package, right? That people get as one of the basic things you get, as opposed to looking at an optional, additional thing that is fringe to whatever the core financial protection benefit package is, right? And we can make that economic argument. We can look at the disparities. We can look at the catastrophic implications of out-of-pocket expenditure for oral care and dental care in general, and make that argument, because and that would also help convince those in Treasury, those in ministries of finance globally, and those who are designing benefit package for insurance, health insurance schemes, or other payer mechanisms as to why they should be part of it. So just some thoughts, but I definitely think, and I agree, that the push for universal healthcare coverage presents an opportunity to make sure that this is part and parcel of what is being considered, and that we should do so in an integrated manner. I am not an expert again, but
I
some perspective.
I completely agree with your comments, and I'm curious if you think that our recent experience with COVID and the spotlight that it has put on the fragmentation in so many of our public health systems has created a new energy, or will serve as a catalyst for more thinking and more action around integrated health systems, particularly ones that focus on primary and preventive care. And is that an opportunity for us to provide better, more responsive care, to create more resilient health systems? And then we could also talk about differences in health system strengthening for middle income versus low income countries, per one of the questions in our chat.
Okay. So COVID, I mean, really has been for many countries, it's really been an inflection point and a watershed moment of sorts, right? It's disproportionately affected us all. I think we know that, more than 300 million people were affected, if not more, all over the world. I think for 5.5 million people died. In Africa, that's about more than 220,000 people. I mean, the statistics are staggering, right? And it's also, impacted the economy. So a lot of economic contraction, and even health spend has declined, because as a proportion, even if it stays steady, has increased as a proportion of general government expenditure. And so definitely everyone has been hit by it. There are certain things in COVID that's I would say that the bad news, right, was One, apart from the mortality, was what I consider to be sort of the decline in global solidarity, right? When there was a rise in vaccine nationalism, it's laid bare the gaps between wealthier countries and less wealthy countries. And it's also exposed the limitations, the underbelly of the global health architecture as we know it, right? Where these entities could not respond to close that gap at the time where it was needed. And particularly in Africa, where access to the vaccines became a major issue. The second thing was I'd also exposed that public health as a whole historically had been based on certain constructs. So in Africa, that diseases would start from there, and we put systems in place to prevent those diseases from going elsewhere. Whereas in COVID, it started from elsewhere and then came to Africa. And then lastly, when you look at how you assess healthcare systems, we also need to rethink and double click on that. If you looked at the Global Health Security Index, most of the countries that were worst hit were ranked really high in terms of their level of preparedness for an outbreak. America was one of the top, and because we looked at just the inputs and the physical infrastructure, and many countries in Europe that were significantly affected, and many countries in sub-Saharan Africa naturally were ranked the lowest in terms of the global health security indices, right? But when the pandemic played out, we found that some of these countries that were ranked really highly were not prepared, and for many reasons, right? And some of these countries that were ranked really low mounted very effective traditional public health responses. And so it also is an opportunity for us to rethink how we assess preparedness of systems to respond, to things. But on the other side, it's been a phenomenal opportunity because one, it's increased a level of introspection in Africa. In the US, new technologies that we don't have mRNAs as another, arrow in our arsenal or in our quiver of interventions for future outbreaks. The role of healthcare and public health is now more mainstream than it has ever been. And so policymakers now engage in healthcare, as they should have anyways in the past. But I think that's now created a level of urgency and interest
Yes.
in healthcare. So that's a good thing. And then the technologies and interventions that have followed. In sub-Saharan Africa, it's the things like the African Medicine Agencies and the Africa CDC and the institutional framework for handling pandemics has been strengthened significantly as a result of the COVID. The quest and the clamor for local manufacturing of vaccines and other pharmaceutical products has increased because the continent doesn't want to wait for another pandemic to realize that it can't depend on the global health system in order to protect its population. I think that's a good thing, and that will begin to reshape the way we think about healthcare. And it has fostered collaboration across countries in sub-Saharan Africa, and regulatory systems are being strengthened. And so that can only be a positive thing in my perspective. So although it's been hard and we've been severely affected by it, I think the world has, a couple of silver linings that we can look onto. And that's why there's a lot of emphasis that should be placed on how we rebuild following COVID. Are we going to rebuild those same inequitable healthcare systems? And is the global health infrastructure going to remain lopsided as it is? Do we see a sense of in global solidarity? Or are we building systems that would quickly revert to unbridled nationalism in the face of a pandemic, when we know that a more cooperative approach will give us better outcomes globally? And so those are questions that we need to answer as we rebuild the global health architecture. And hopefully we will get it right and at this time, because the viruses are in the fight battle between viruses and humans, right? It's an age-old one, right? And we need to collaborate better in order to address some of these things.
Right.
A lot of thoughts, right?
Yes, yes. It's really a lot to think about. And you've commented a little bit about the role of the private sector. We do have a question that has come in to the chat asking about private community religious-based systems and what sort of role they might have, along with donors and NGOs. How can they work with governments and others to help affect change?
I think they have a very significant role to play in many parts of the world, including Africa. We have the private, non-for-profits, sometimes religious organizations playing a huge role. Even in the United States, if you look at the names of some of the hospitals, right. You would tell that at some point, there must have been the influence, if not, the origination by faith-based entities, right, in establishing them. And there are multiple reasons for this, right? Sometimes they complement what the government has provided. Sometimes faith-based organizations reach the vulnerable. They also reach those who the government may have intentionally neglected or inadvertently, just not gotten around to. So I recall, like, even as part of Gavi's strategy to reach, 0 dose children with immunization, those are households and families that have never been reached by vaccines. And some of those families and households and communities actually suffer from multiple deprivations. So if they've never been vaccinated, it's more likely they've never gotten access to any maternal health service or other child health service or any other sort of like healthcare intervention. So, and in some instances, it's faith-based organizations and some of these, NGOs that understand those communities better, understand their needs, can provide culturally appropriate care to them, and actually have the trust and confidence of those communities and can reach them. Because so their role is vital, right? And their role is critical. Public policy needs to acknowledge this, and it needs to be built into, the overarching narrative about service delivery. The government shouldn't look at them as being in competition with public provision of services, but rather as being complementary to what they are doing, right? And that's really my perspective. And I've seen them work in many places, and that's really. I think it's a great point. They have a significant role to play in some health systems, like in Ghana, and I believe even in Zambia and some other places in Africa. You do have more formalized relationships with governments in terms of service delivery. And in some other places, they just act autonomously, working with communities, trying to reach people who have never been reached before. But it's quite essential.
We have a question in the Q&A from Dr. Swan. Many low-income countries have some of the world's most lucrative resources, yet these people are often denied access to vaccines and access to care. Would these not be needed in order to sustain the workforce if we are going to access the lucrative resources? So why aren't we taking good care of people in order to optimize
the resource? So absolutely, and we find that sometimes like some of the lower middle income countries that are resource rich not only have some of the highest burdens of disease, right? So we know that you know, for instance, I'm Nigerian. Nigeria has some of the highest maternal mortality ratios in the world. It has the highest burden of malaria. It has, probably top 5 in terms of TB burden, HIV burden, rising NCD issues. And so the amount of challenges that it has to face, it will really need an exponentially more resources that it has to actually address that, right? So just the burden is one thing. The second thing is really the prioritization in the health in the budget, right? I think we underspend. On average, probably the government spend maybe 5% to 6% of their budgets on healthcare in terms of general government expenditure, and that needs to increase. Most of the healthcare spend in many of these countries is out of pocket. In Nigeria, about almost 70% of healthcare spend is out of pocket. So there's a need for more investments, right, in healthcare in these countries. And I think that's a government's issue. I think to the question that was asked, should governments do more with the resources they have generated? Yes, they should do more in terms of healthcare, but they also should do more in education. Some of the social determinants of healthcare are really important. But there's an angle I want to bring to this, which is the fact that we need to reimagine healthcare differently, right? And there are many reasons for that. I mean, we've seen the issue with the social determinants, with climate change, the environment, etc., having malnutrition and food systems, the impact it's having on healthcare. We've also seen that it's really, we are fortunate that we do not have some level of path dependency. So the epidemiology transition is happening really slowly, where wealthier countries went from being, from the burden being mostly from type 1 diseases, so perinatal infectious diseases. And as the economies grew and they developed, the burden of those diseases dropped significantly, and they began to see more NCDs, etc. What you're having now in many middle-income countries is the burden of infectious diseases still there, hasn't declined, but the burden of non-communicable diseases is rising. So you have what they call a dual burden of disease, and in conflict-affected areas like the Sahel region in Africa, in the northeast in Nigeria, and some other places, triple burdens of disease. So what that means is that there's no respite for the healthcare system, right? In resources moving from one end to another. So then what would you do if you were trying to redesign the system? You can't afford to design a system modeled after some of the rich countries because you cannot just afford that, right? So
not sure we can either, but
it's true.
Sorry.
And then third, in terms of financing, there's a high level of informality in the economy. So even if the GDPs are growing, or you look at the GDP per capita, that makes them middle income or whatever, for that GDP to translate into revenue, the governments have to tax it. The tax base in those countries are very low because it's a very informal economy. So there's an overdependence on, overseas external assistance, which is not sustainable, not predictable for the countries. So we need to rethink how we finance care and what the service delivery models need to be. We need to and invest in disproportionate on primary healthcare, on prevention, but also on the promotion and production of health, thinking climate, thinking the environment, and how we have health embedded in all things. It's really important because the curative-based, disease-based health systems are not just going to be there. There's a human resource crisis due to either migration or just not having, we're never going to have enough doctors per population to meet the global norms. But with technology, do we need to have those numbers? And how we're addressing allocative inefficiencies. So I think back to some earlier point I made about how we rebuild, there are lots of questions that need to be asked. And so the way we rethink and rebuild the health systems in Africa and other countries really matters because cost is going to be an issue. and financing is going to be a major issue. And we don't want to wait until, I think by 2030, I mean, Africa would have, like the largest population growth we're going to see is going to come from Africa, right? I think by 2050, Nigeria will be the third, will overtake the US as the third most populous country, like only China and India. So we're looking at populations that I hope we'll be able to sustain. And if not, how do we invest in women's education, in family planning, in empowerment? And so really rethinking what we need to invest in to get the health outcomes we seek. Some of those investments will go through the health system. Some of those investments will have to go to other social determinants of health outcomes. But we have to have a coordinated and comprehensive view of what we're trying to achieve and look at the interplay between epidemiology, demography, and the macroeconomy. And these conversations cannot be had in silos. But I think it's something to really look at as we emerge from COVID and take all these lessons learned and build more resilient and sustainable systems on the continent.
Absolutely. And thank you for bringing up the question of how we train health workers. As I listen to you when we talk about integration and we talk about sustainability and redesigning systems to promote health and prevent disease, it seems that we need to think about training our health workforce differently. We need to, well, in places like the US, perhaps train fewer specialists and more generalists and more individuals like community health workers who are focused on preventive and primary care, but also transforming the workforce in low and middle income countries to help with things like brushing teeth, with hand washing campaigns, with public health messaging about how diet may influence health, et cetera. Could you comment on investments in education? You mentioned one of your mentors earlier, Dr. Paul Farmer, and we worked with him in Rwanda at the University of Rwanda, and are in conversation to help with the University of Global Health Equity's curriculum around dental care. And they have a really unique, I think, curriculum where they are trying to create providers who are equipped to work in a more integrated population health focused system. And I'm just wondering if you see that as the future, and if we need to revamp our educational systems, how do you see the private sector potentially assisting with that? We have a question about whether the private sector is ready to engage for the long term. I think if we want to make some of these changes for universal health coverage, we need to change where and how we deliver the care, and potentially who is delivering the care, and maybe engage individuals more in their own care than they have been traditionally.
Yeah, absolutely. And I am familiar with the University of Global Health Equity. I think it's really amazing what the Harvard is doing there in that collaboration. One of the things I worked with Marco OGCH on was on human resources for health. The book is actually on that. So there are lots of things to reflect on with regards to the health workforce. And the entire value chain, looking at how you produce them, so how you train, both pre-service training but also in-service training, how they are sort of managed, allocated to places to meet the needs, how they are incentivized or disincentivized in the system. So there are different areas to that. I'll just touch on a few points. One is the entire healthcare value chain. We need to look into that. So most times we focus on the doctors, the nurses, etc., which is critical and it's important. When you speak to even the private sector, when they come into a country, either they invest in hospitals and they want to scale, the first issue they come up with is the health workforce. and how do you get enough specialists, doctors, nurses, I have to say dentists because we're talking with the dental school, and other, health workers along the healthcare, across the healthcare value chain. And then you look at how many products are coming out from the universities, how many of them have the right level of postgraduate medical training, and also how many of them, while practicing, are constantly accredited or go through some form of continuous medical education to foster good quality care. And it's limited. So there's a need to scale up, right? Training. And then the next question you'll hear when you hear about scaling up is, well, they're going to leave, medical migration, right?
Right.
And I personally, my own personal view is that you can't force people. I mean, every human being has a right to exercise agency in charting their own path, right? And so I've heard a lot of, draconian things being said, oh, ban them from leaving, or ban this. I'm like, but I think people can chart their own course, right, in life. It's up to you from the public policy perspective to incentivize people to stay or to leave. Labor will always be mobile. Even within countries, you have to incentivize people to go to underserved areas. Otherwise, everyone will cluster around the cities where everybody wants to live, to live in. So it's a constant thing that policymakers have to grapple with, and people have to have a more balanced perspective of that. The third thing to mention is there's a huge role and I'm now speaking about lower middle income countries where the diaspora from those countries can play, right? So there are lots of African doctors in Europe, in the United States, in North America and other places. Is there a role they can play in training in those who are there? Is there a role they can play in spending some time giving back? And I think beyond just the ad hoc charitable gestures, is there a more coordinated way we can harness the power of the diaspora from these countries to actually contribute towards building the health workforce of the future? Then the one more thing to some other things to mention is really that with technology, there is an evolution in terms of what tasks can be performed by home, right? So perhaps, more task sharing and task shifting can occur, right? Similar to what's going on in the US, where you have a lot more nurse practitioners overseeing, providing primary care services. What tasks in those countries can be provided by other cadres of healthcare workers, and should we have a rethink of the residency programs there, and have a primary surgical residency program, for instance, since essential surgery is important, right? And not wait for people to spend 6-7 years in surgical training before they are attending surgeons. So can we innovate around, the way we train, the way we shift tasks across different cadres of health workers? And then I think just lastly is really the question about building, about partnerships with institutions. So the same model in collaboration with the University of Global Health Equity, is there a more intentional way to partner with African institutions, whether it's universities, etc., in undergraduate, or what we call undergraduate medical education, which is becoming an MD, or postgraduate medical education, which is specializing on doing residency programs? And I think that should definitely be explored, because I think there's a lot of opportunity there. I'm conscious of time, so just trying to keep it.
Right. I know we're just.
I could talk about
I know this has been fascinating, and I think we could go on and on. So I'll just ask you one last question. We have a couple other questions in the chat, but maybe I can connect folks with you after this. But just for our students, if you who are thinking about their careers and what they might do next, what one piece of advice might you do? Would you offer for our students who are trying to think about how they can engage and make a difference? So many of them are interested in global health issues and trying to get out there and serve those in low resource areas. What would you say to them?
I think it's I mean, I will sleep better at night knowing that there are people who actually want to correct global health, because it means that they care about, because global health really is about healthcare that is aimed at ensuring lower income settings or more vulnerable populations get access to care, right? I'm not sure, my understanding of global health doesn't mean billionaires access to healthcare. No, it's about the poor, or it's about a term we coined in the social impact investment company that's, Flint Atlantic, that we set up. We categorize a lot of people as health poor. So because that included people who were too poor to afford healthcare, but also included people who had the means but did not have access to good quality care. So both were health poor. And so I see global health as trying to address those things. So that there are students who are already thinking about these problems, whether it's in the US, looking at disparities in healthcare within the US, or if it's looking at disparities across countries and even within countries outside the US in the what we call the developing world. So I will sleep well at night now knowing that there are people that will continue in that trajectory. So I think fantastic decision. There are so many things to unpack. It will stretch you in many ways. What I've advised some students here at the Harvard School of Public Health to do is, as you're building your career, when you begin to engage in global health and development broadly, you'll find that it's extremely valuable for you to go deep in what you have. So retain the technical depth you have, because that's sort of your first mode of engagement into a problem. But it's equally important to invest in breadth, right? So they call it T-shaped skill sets, right? So, and the breadth is really trying to understand socioeconomic determinants of health, understand how systems work, understand a little bit about how, maternal education is probably the most singular intervention you can make if you want to reduce childhood malnutrition or under 5 mortality, and the intersection of empowering women and educating them in some of these settings and the health outcomes you would want to see. So build breadth in your journey, because that helps you become a more effective global health practitioner. And third thing I would say is, like it happened to me, really was really stay intellectually curious and ask questions always. And then finally, you're in an institution that has amazing resources. Don't wait until you graduate before or you finished your career path before you then delve into that. It might just be a course, a class you're taking, might just be seminars you attend, but stay engaged, because the issues are evolving globally, and dip your toe into global health. If you have the opportunity to spend some time outside the US to see what health practice in other settings looks like take the advantage. It's a month. So just stay engaged continuously, and that will help shape the way in which you want to play, because there are many ways you can be involved. You could be a researcher in global health, you could be a practitioner, you could be an instructor, and you could work at policy level. So, but that's a journey you want to get on. I begin to a journey of discovery as well. And I think you're in a fantastic institution that has all these opportunities. And I think, as you focus on graduating and, getting your grades, also think about expanding, your knowledge base, and also taking advantage of the opportunities that you have. and stay in touch.
Ohiri, this is fantastic advice for our students. Thank you so much. I love your tea, and I may quote you on that. But this has been a fascinating conversation, and we so appreciate your time today. And from HSDM, all our students and faculty, thank you very, very much for joining us today for our Global and Community Health series. Take care. Good afternoon, everyone. Bye-bye.
Thank you for having me. It's a pleasure.
Thank you. Bye-bye.